Before I go, I really wanted to bring up my article. I was limited on the amount of slides that I could put on my PowerPoint because I'm trying to meet the guidelines, but I do have a little bit of time left, so I wanted to take this time to discuss the article and discuss the pictures on the Science Direct article because at least this picture for me really helped you understand what involucrum is, the cavity, the pus, the sequestrium, which is kind of um, stages, right, of either bone breaking, bone healing, and us seeing where this osteomyelitis is headed. So if we see kind of like an initial infection, are we at an acute point or are we already seeing a cloaca and a sequestrium? So are we leaning more towards a chronic? I also wanted to highlight this next picture here, which is a classification system for osteomyelitis by Cerny and Mater. So stage 1 is this medullary osteomyelitis. Stage 2, superficial, 3 localized, and 4 diffused. So it's really important in the anatomy of it because say we're catching something early on, like my John Doe from my Friday patient, and once we actually do the excision of the bone, we can actually appreciate if we decide to take it to pathology or whatever the protocol is. We can actually see what stage that bone was in. For example, here, the most common host is diabetes, malnutrition, renal failure, which is exactly what we're dealing with the patient that I was talking about. Another picture, because that's more proximal tibia, but another picture was this right here, which is something that I haven't been exposed to a lot or ever. So this diagram here shows Mascalet's reconstruction technique and stages of bone transport. So Mascalet induced membrane technique right here in A. And this is kind of how we can like patch up the bone and fixate it and bring it back to its normal state. Now on the foot, it's definitely different, and we usually opt for the amputation option. But I think these classifications are the closest we get to quantifying osteomyelitis, right? Because you see it, you're like, definitely osteomyelitis, let's amputate. But it's hard to quantify at what point we are at. We know, like we mentioned earlier from the NCBI article, that when you have a patient that is presenting with an x-ray like that, because x-rays are not so sensitive, right? So this patient had to have at least had that for it to show on the x-ray for about 6 months, even though he is sure that it has been 1 week. So one, I think from my personal experience this past week, I wanted to highlight the importance of imaging, because one thing is what the patient tells you, and another thing is your own protocol, right? Like normally, based on what that patient told me, had it not looked so bad, maybe we would have just cleaned it up. I think I added a picture there of me flushing it with saline and adding some Silvadene and bandaging it. Normally, if it didn't look so bad, you would just send the patient on their way because you wouldn't even be suspecting osteomyelitis, which is definitely what has happened to him, because we've seen him. Last time we saw this patient was about 5 months ago. And he said this only was a week ago. So it's interesting that we are getting closer to quantifying osteomyelitis, as difficult as that sounds. And it's good to learn about these classification techniques and these like bone transport mechanisms to fix it, right? Maybe we are closer to also getting rid of amputations and maybe being able to limb salvage a little bit more. So thank you.